Recording in progress.
All right, now we did it this time. Yay! Hey, everybody. We have, can everyone see me?
I can. Mike in
Okay.
California can.
Mike in California can. So if Mike in California can, everyone else should.
I'm a long way from you, that's for sure.
Yes, you are, Mike. Thank you for being here. Thank you for attending. I truly appreciate. Hope everyone can see me okay, hear me okay. Um, we are going to be providing you guys with the recording of this and a handout with like a summary of everything we're going to be talking about today. So today, let me introduce myself first, right? So my name is Marcia Perretto. I'm a doctor of physical therapy. I'm a certified orthopedic manual therapist and a bunch of yada 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 after my name too, but that doesn't matter. I'm a founder of Active PT in Boca Raton, Florida, and my clinic is specialized in working only with individuals who have Ehlers-Danlos syndromes, hypermobility spectrum disorders, and any related conditions like postural orthostatic tachycardia syndrome or POTS, mass activation syndrome, MCAS, cervical instability, upper cervical instability in general, and all the other issues that are a consequence of living with Ehlers-Danlos syndrome. I bring over almost 3 decades of experience in movement science, neurology, neuroscience, and orthopedics, and etc. I have been able to I have been honored with the opportunity to practice in different levels of the healthcare system throughout the years. And because of my own journey, I had to, as a patient with Ehlers-Danlos syndrome, hypermobile type, I like to think as a blessing in disguise, the opportunity to learn what this is and to research and now to dedicate my career in helping people with connective tissue disorders not just manage symptoms, but actually thrive. Um, and so, in addition to treating patients, also I collaborate with top specialists nationwide. I lead workshops, I develop educational programs for both patients and clinicians. And my ultimate goal is just to empower individuals like you all to move safely, reduce pain, and rebuild confidence in your body and to be able to have a more fulfilling life. So, without further ado, today I would like to cover with you guys the topic of moving with confidence and managing your hypermobility and EDS symptoms more safely, so you can live a better life. So, I'll ask everyone to just mute their microphones so we can actually make sure that the content is recorded correctly for everyone else that is might not be present or might get the connection interrupted, the audio interrupted because you might have a background noise. So please take your little bit of time and mute everyone. Everyone mute your microphones. I appreciate it. If you do have questions, I encourage you to put your questions in the chat as we go so you don't forget the questions. And then we're going to go over the questions at the end. Um,
You are muted.
How did that happen? Thank you, Cheryl, I guess said that, right? Thank you. Somehow I muted myself. So today I would like to talk to you guys a little bit about the EDS, the challenges of movement, practical strategies, and how to safely move throughout exercising. So like a little overview, what is hypermobility, right? It just means that our joints move beyond the normal range of motion due to difference in your connective tissue. However, it's not as simple. Some people experience this without any symptoms at all. They live a life without any problems, while others will face joint instability, pain, frequent injuries, dislocations, and all other comorbidities that can come with this diagnosis. think of your connective tissue as more like the scaffolding of the scaffolding that holds your joints together. And in hypermobility, this scaffolding is weaker, leading to excessive movement and a lack of support and chronic micro injuries and eventually major injuries when we get a dislocation or when we exercise and end up injuring ourselves. So, Ehlers-Danlos syndromes obviously are a connective tissue disorder that affect collagen, and which is the protein responsible for the strength and elasticity of our tissues. And that collagen at that point does not it is not strong enough to support the required movements and the required stability of our body. So this will affect not just the joints, but actually our entire bodies, right? So we are more prone to subluxations, dislocations, micro instability with general day-to-day movements, chronic pain due to overuse or muscle compensatory movements because of weak joints, the fatigue that's often linked to that muscle overwork, right? Because our body is trying to compensate that so much that it's tiring. It requires a lot more energy than someone that would not have the same diagnosis. And then obviously there are systemic conditions like POTS, MCAS, and other things that can coexist. Uh, there are proprioceptive challenges as well, where the body struggles to sense the position in a space, which is a big issue that we notice, and we all can can vouch for at least walking onto that door frame a couple times a week, right? So looking at the systemic challenges of the EDS now, it often comes with comorbidities, right? So POTS is one of them. So we will stand up or we'll try to exercise, and in a standing position, an upright position, we'll experience dizziness, lightheadedness, fatigue. We will not recover as well. Um, and then we have mast cell activation syndrome as well, for example, which can trigger allergic-like reactions during stress or in physical activity, because physical activity is a stressor to the body. So it can trigger a mast cell reaction, which will make you wake up next day feeling like you got a flu, right? A sensation of body aches and things like that. Um, Gastrointestinal issues as well will affect digestion, energy levels, and recovery. If you cannot digest, you cannot absorb ingredient or nutrients. You cannot utilize those nutrients. You're not going to have the gas in the tank to take you to your destination, which is becoming stronger and healthier, right? So these systemic challenges literally just mean that we need a tailored approach to exercise that will reduce the risk reduce the risk of becoming or reducing the risk of hurting ourselves during the activity, the physical activity, reducing the risks of having a reaction post exercise session, right? So we can build the stability, we learn to respect our body's limitations, and we actually progress instead continue to injure ourselves over and over again when trying to do something. So let's see how we can actually do this more effectively, right? So there are several challenges for us uh, when we are hypermobile. For example, physical challenges. The biggest one is the joint instability. Without proper muscle support, so we have the passive um, support system and the active support system. The passive support system is our ligaments, is the capsule that involves that joint, and that should be giving the joint some sense of protection and stability. Then the muscles come as a second layer with their activation, and they stabilize the joint even further. Well, collagen is part of both systems, right? So when the collagen is deficient, that capsule, that ligament is now not as strong. We stretch to that, not intentionally, but due to that instability, we keep pushing through that limit. We cause a laxity to that tissue. It becomes looser. So imagine now that you're wearing a t-shirt a size bigger than your normal size, right? And then your muscles are not able to give that same control and stability to that joint. So that is uh, the physical, one of the major physical challenges we'll experience, which will lead to micro trauma, overuse injuries, and then that cycle of pain dysfunction over and over again, right? The next challenge we experience is actually fear of movement. So many of us may feel afraid of exercising because of past injuries and pain. I've been there. I felt that way. I felt like I couldn't do something again because I got injured once, twice, three, four, five times doing the same movement. Um, and this fear is valid, right? Because we've been there, we get hurt, we try to avoid it. It's just natural defense mechanism that we adopt. Point is, we need to learn how to get to that movement without injuring ourselves, right? So over time, we need to create stability so we can actually work throughout our daily activities or even go into an exercise session, knowing our limits, knowing how far we can get, and then making the adaptations that are necessary. Then obviously we have the misconceptions about exercise, right? So the common advice that, oh, you're feeling, because we do feel tight, right? We're hyper, it's almost contradicting, right? Why am I feeling so tight if I'm hypermobile? Well, your superficial muscles will get into a muscle spasm. Your primary movers, like quadriceps, like hamstrings, like this big layers, calves, the superficial layers become tighter in attempt to compensate for the deep stability system muscles that are actually now not kicking in due to chronic pain, due to not being active appropriately because of the instability. So those superficial muscles feel tight. What do? We want to stretch them. So it's a catch-22 with that, right? Because um, it feels good, right? It does feel good to stretch. But if we take that stability out, that stability serving as a purpose, the first question will be, do I really want to remove that fake sensation of stability, yet serving a purpose? And some of us might have experienced this. You stretch and then you feel like discombobulated. That's the word I have heard a lot here in the office, right? Yeah, it feels better, but now I feel like discombobulated. And or we do a stretch session, and instead tackling the muscles because we're not aligned correctly, we end up stretching the ligaments and the joint capsule, feeding into more instability later on. So the advice to stretch more is not correct. As well as the advice to do high intensity workouts, but there is a balance and a place for each one of those, right? So they need to be modified to fit our needs. Um, Passive stretching with prolonged holds can destabilize the joints even further, while high impact exercises can overload the fragile connective tissue that we have and lead to micro trauma. So initially, what we really want to do is to focus on stability, on a very slow graded progression, and controlled movement, right? So, and also then we just have to remember the impact of the comorbidities in that, because that needs to be equated on your program. So if you have POTS, if you have mast cell, that can complicate exercise, right? Because for someone else could be exercise in a standing position. Someone with POTS may limit maybe limited the tolerance for the upright activities. And if you have thoughts and you can be doing great today and tomorrow, you might have to exercise in a recumbent or lying down position. So even in the same person, there are changes from a day to the next, right? As well as mast cell will require a more careful pacing because we do not want to trigger symptoms because of the physical stress. So understanding, okay, I exercise this much, and that also changes, by the way, because there will be other stressors in life, right? So if you're going through a family situation, if you are going through a, let's say you're moving, you just came back from a trip, and normally a set of exercise will not trigger your mast cell, but you had that stressor the day, the 2 days, the 3 days before, you haven't recovered, you might trigger your mast cell with the same set of exercise that never triggered anything before. So again, same person, different presentation that day can be a cause a flare of symptoms. Okay. So let's look at practical strategies for safety during exercise, so you feel safer and more confident during movement. So I kind of like to work out of five principles. Uh, in my 30 years of experience with movement sciences and in my like 14 years working with EDS exclusively and its comorbidities, uh, I have come up with or come to observe through research and patient care and my own personal experience, which obviously also counts, is that there are five principles that I really like to use and focus on when building a program. Okay. And remember, we need to pull in the other diagnoses later into these principles. But stability before mobility, right? So start with exercise that builds stability first. Why? Because we need first to activate muscles that have been dormant, that have been underactive. Some people might say, well, if my glute is not working, no. Yeah, we might tell you, hey, your glutes are not working. Not quite the line that we should be using. They are working because if they were not working, you would be folded in half with your nose on the floor. uh, they are working, they're just not working efficiently within the myofascial line to provide you with proper um, muscle activation in the sequence that it has to be. So you're compensating and you're getting injured, and then there will be inhibition of the muscle to a certain level, in the inhibition of the deep joint stabilizers because of pain, and you start compensating the movement. So we want to start with things that activate muscles, with activities and exercise that activate muscles. Like isometric is a good example for, right? But doesn't necessarily has to be the only one. Um, we need to utilize closed chain, which is meaning that your foot or your hands is touching a stable surface, like a wall, a floor, something firm, right? And then the sud closed chain exercises that I always talk about here at the clinic, which is your hands are now attached to a bungee, to a rope, to a ball, to something that's moving, but yet you're attached. That doesn't count as dumbbells. Dumbbells are free in space, right? Um, so principle two is that I use shortened levers of movement and controlled movements. What is a shortened lever? It simply means instead using your arm straight, bend your elbow. Instead using your leg straight, bend your knee. How can we shorten that movement, bring it closer to the body, right? So we decrease or we reduce the strain on the joints, right? Just by bending the knees, for example, on a leg lift, you're already protecting your hips and your lower back. So just think about that also in your functional day to day. Instead, reaching across that table with the elbow straight to reach for something far out and strain the shoulder, can I get closer to the object in any way and not straighten my elbow that far? Okay. Um, I also want you to think about slow and deliberate movements. Like, uh, let's put it this way. If you're doing a leg lift, instead just lift and lower, engage the muscles, think of what you're doing, and then moving in a count of 4 to 5 to lift. Give yourself 2 or 3 seconds and top, lower with a count of 4 to 5. Keep the movement mindful. This way, you're protecting the joint, you're activating the most of the muscle fibers, and you're activating type 2 muscle fibers, which are essential for joint stability. This is research. This is as black and white as it can be. All right. Uh, Principle number 3 is incorporating ground reaction forces. It's like, what? Yeah, that's essentially the force that the floor will give back into your body when you apply forces onto the floor. That also means that the same force that you apply on a wall is going to be responding back to you. So it's not only even what's called ground force reactions, it's surface reaction force, more so than anything. So, because this type of exercise or this type of incorporation of principle will improve your proprioception, will improve your stability by facilitating muscle engagement. So it helps your body literally to learn to stabilize naturally during day-to-day movements. Um, my principle number 4 is literally managing connective tissue load. What does that mean? Gradually and controlled stress helps to build connective tissue. It helps it to adapt. So if you're doing the same set of exercises over and over and over and over, nothing changes, your body will accommodate, you will not progress anymore. You need to have a gradual, however, controlled slash graded, right? Because you need to know how much works for you specifically. And that's where we come in as therapists and a trainer or instructor that is versed in how to work with the client with EDS as well. It will understand the principle. It will assist you with adapting and building the connective tissue through load management. So you start with a light resistance, for example. You will avoid prolonged static positions with that load, and you will start adapting the tissue so you can make progress. And then obviously, principle 5 is building confidence gradually, right? So small wins build momentum. So focus on achievable goals. I know that sometimes we're like, but I used to run and I want to go back to running. But right now you're even having a hard time walking. So how can we break this down in a way that you can see a goal to be accomplished instead looking forward to the running, and that running could take years to happen or may not even be indicated in your case anymore, and then you get frustrated, so you won't be confident that you're actually making progress. So small progresses, like when I was in a wheelchair and then I transitioned to crutches slash a walker, and I live in a 3-floor townhouse, and I always say this, my stairs look like stairways to heaven every time. And when I stopped using this going upstairs, I used to sit down actually and do and climb the stairs seated on my bottom, or come down seated on my bottom because I was afraid of falling with the crutches because I wasn't very coordinated. Um, when I started being able to actually climb the steps, even if I did that one step, other foot, another step, another foot. And then my next goal was alternating steps. Those are successes. It might not seem much, but if you celebrate the small wins, you're going to start becoming more confident, and it will help you to build more trust in your body as well. Okay, so progress is slow, but progress that is slow, but it's steady, every step forward is a victory for us. So I just want you to also think that we are going to have step backs. So don't think that is a steady upward curve. It might have dips, so it's hills and valleys. But you're also gonna notice that you're gonna have sometimes the space in between your flares are gonna be bigger then your flares are going to last less time and things like that. So you start looking at things, small details. You might be able to sit 5 more minutes than you used to. That's a win. Okay. So I guess I actually went through the content faster than I anticipated. So my goal was to give you guys about a 40 minutes lecture, it's 30 minutes into it. So I am able to actually answer more questions than I anticipated. So let's go for it. Does anyone have any questions?
Question that's in our chat from Meredith is, do you recommend different PT activities for the different EDS subsets? For example, CEDS versus HEDS.
So it's again like we're looking at different people, right? So obviously, if someone has vascular EDS, there are precautions and contraindications compared to someone that has AGDS or CEDS. But also, we are so different, right? Some of us have AGDS. Let's say we get two people with hypermobile Ehlers-Danlos syndrome, and someone will have way more vascular fragility than someone else. Or that person with hypermobile Ehlers-Danlos syndrome has a gene that makes them to be more prone to blood clots or bleeding versus the other person. So I need to take that in consideration when I create. So it's not really a subset or a set of exercise for each diagnosis, but a set of exercise for each person, taking into consideration all the issues that that person individually presents.
Thank you. I appreciate it.
Of course. So anyone, I mean, you guys, just raise your hand if you have a question. Let's make this a very interactive session. Let's chat. Anyone has any more questions here that would like to speak up as well?
Marissa said, do you have some recommended workout types or moves that you could share for EDS with POTS? For example, Pilates versus yoga and movements that are successful. And meantime, we should remind them that you're going to be at 3 o'clock tomorrow. You're going to be on live with Dr. Brent Anderson from Polestar Pilates. So
Yeah, we're going to be talking more and evolving this on the subject even further. But yeah, there will be a lot more information there too. So when I work with POTS patients, the first thing I would like to always teach is for POTS. So that's the difference. You see, when you have POTS and now you have AGDS, you have two, I don't like to say two sets of exercise, but two principles that you have to do. So for AGDS, hypermobility, the connective tissue, the joint instability, you want to activate the deep stability system. You want to use slow controlled movements and you want to work with the smaller muscles. Now, when you're working with POTS, and that will be your second set of exercises. Now we need to take into consideration large muscles, right? Calves, quads, hams, abs, glute max. We need to use an order because you want to pump that blood from the foot up, right? So you want to get the blood back into the heart. So, and you also have to take into consideration cardiovascular exercises. So when you're doing one you're going to have two routines essentially. One that is going to be the activation routine and the joint stabilization, and then you're going to have your POTS exercises. And then there's obviously all the POTS precautions that we recommend. And then if you're a patient that you experience a lot more issues with your standing up or sitting up, we're going to have to start to more in a lying down, sideline position or recline position. And if you're a patient that has more tolerance already, you have your better cardiovascular system, you are going to tolerate more of activities that are standing, activities that are more higher level, let's say.
All right, the next question. Do you think running would be contraindicated if you have Chiari malformation? And you should probably explain what Chiari malformation is.
Okay, so Chiari malformation is essentially when the ligaments, you guys can see me, right? Because I see my face for some reason, but I don't see my image. I think we're okay. Great, thank you, Marcella. So Chiari essentially is when the ligaments at the base of your skull become a little lax and you start having an invagination of that bottom of the brain tissue, the brain stem. Everything kind of sags a little down, okay? And it starts compressing. That compression can cause a lot of symptoms, right? We can probably do a lecture on Chiari malformation. Patricia will be great. Usually Chiari malformation kind of follows hand to hand with cervical instability, which is another issue, or upper cervical instability, which is another issue. Point is, running, see, again, it depends on each one of us. I personally, if you already have hypermobile Ehlers-Danlos syndrome, I would prefer you not to run. I would prefer you to use the elliptical. I would prefer you to power walk, but avoid running just because of the trauma on the joints itself. But let's say you are stable enough and you're okay with running. You're the one patient that can run. If you're not, it's always based on symptoms. You're not symptomatic. You have no pain. You have no neurological signs. Okay? I would say it's okay for you to run, but watch yourself. There is no need to run as well. Okay? You can achieve the same results power walking or on an elliptical. I know the freedom of running. I was a runner. I can't, I understand when we say, but I need to run. But I think you should protect yourself. If you don't have any symptoms, doesn't mean you want to dig and find symptoms. It's like that person that says, well, doing yoga, I like to do yoga. Can I do headstands because I have upper cervical instability, or I was told I have a Chiari zero. Why would you want to do a headstand and compromise your upper cervical, even thought you don't have any symptoms now? Because once you develop symptoms, it's harder to take it back. So that's kind of what I would like you to pay attention and make a decision, right? Some people say, I want to risk it. It's important to me to run. But I cannot recommend you to run even though you don't have symptoms, because you would not be able to take those symptoms back if they come up.
Thank you. Meredith, do you want to go ahead and ask your question? Put your hand up.
I actually, I'll share a little bit. I have fibro CFS, POTS, and CEDS, and my favorite exercises are actually Tai Chi and Pilates. With the POTS, especially, I found that if I'm having a really bad flare day, then I'll do my Tai Chi seated, and I don't have to worry about anything like that. Or like another thing is the recumbent bike, because again, I'm still seated, not having to stand up if I'm having a bad day.
Excellent. It's excellent. You see, you already found, you already understand your body, right? And you have no problems, because sometimes we have that competition with ourselves, right? I can do all this, and today I'm not having a good day, but I want to push through. It's smarter to do what you're doing. I'll take my Tai Chi to the chair. Oh, but I do yoga. Take your yoga to the chair. But I do Pilates. Take your Pilates to the chair, right? You have a recumbent bike. Do a recumbent bike instead, going power walking to work your cardiovascular system. Perfect, Meredith. That's exactly what I like to hear, that you're listening to your body and you're adapting based on your needs for that specific day.
Thank you. And that was Meredith, chronic fatigue syndrome, and recommendation if you're falling asleep every 2 hours, what to do. Also from Meredith.
So, what is the question again? I'm sorry.
When you have chronic fatigue syndrome flare and you're falling asleep every 2 hours, is there a way to
Oh,
kind of overcome that or ameliorate that?
well, what is causing that? Um, what is causing that to happen? Let's just start with that, right? Why are you fatigued? Did you miss a meal? Did you eat something that could have caused you to flare? Did you, like, are you having a mast cell reaction? You just didn't sleep well the night before, right? So respect your body. If you need to rest more that day, it's perfectly fine. For those with post-exertional malaise, though, it's a bit different. If you tap into post-exertional malaise, that is going to take you days to recover. So it's better off to minimize and grade the exercise better so we don't tap into it, because it's going to be days, sometimes even a month before you're well enough to go back. But when it's just the ongoing fatigue, or you're fine and then that one day you're falling asleep every 2 hours, analyze what happened. Was that a food that you ate that triggered something? Was that environmental? Weather changes can cause significant physical symptoms for us. We're more sensitive than others. Some of us are more sensitive than others, not everyone. So just take into consideration what is happening to your body, what happened, because if it is something you can modify from the day before, like let's say you had a glass of wine, you don't react well, but you wanted to have that glass of wine and now you're paying for it. Now you know it's wine. So next time you choose to drink a glass of wine or you choose to eat that one food, you will know what's going to be next day. Does that make sense? Did I explain? Did I answer your question,
You
Meredith?
did. Yes, ma'am. I appreciate it. I'm actually, I'm only 2 weeks post pneumonia. So
Oh boy.
it's a little bit different.
So yeah, well then it's, you see, being 2 weeks post pneumonia, now we have a whole different thing to deal with, right? Now we are looking not only cardiovascular but respiratory as well. So your respiratory capacity has decreased because of pneumonia. You have lost the strength because you couldn't exercise. Your system was stressed, right? So now it's like you're going to have to peel back your activities and start again little by little. The good thing is that you ramp up a little faster than you did when you first started your journey. But it's gonna be your valley. Remember, I said there are peaks and valleys. You're kind of on a valley right now, but it's going to be a little quicker to get to the peak now, but just take your time and respect your body. But yeah, you see, that's a stressor. There is no competition to that stressor. You're gonna have to slowly build it up. I'm
Thank
sorry to
you.
hear, but I'm glad you're well.
Thank you.
Yeah.
Which exercise is better for hypermobility, yoga or Pilates?
So both could be good and both could be bad. How come? It's what you're doing during those sessions, right? So if you're going to a yoga session and you're pretzeling yourself, if that's a verb, if it's not, I just made it up. You're pretzeling yourself because the person beside you is able to lap the arms twice around their waist before they get to the end range, and you want to do it the same, but they're not symptomatic and you are, you're going to pay for that. That's not good. No one should be going into a full-blown pose if they don't have the strength and the stability to hold that pose. I do yoga. I've been practicing yoga. I was an Ashtanga practitioner for many, many years. I still play a little bit with Ashtanga, just not as powerful. But and I'm a yoga instructor as well. And my highest recommendation on that as a physical therapist, as a movement specialist, as a yoga instructor is keep it within the right range of motion. on that yoga session. There is no point to take yourself to extremes of range, because yoga is not about how far you go in a pose, it's how strong you are to keep your alignment during a pose. That translates to Pilates, right? So in Pilates, the same thing. If you are going to do, let's say, your leg circles, there is no point to make the big leg circle and end up feeling that your hip is all over, right? You can bend the knee, make thigh circles, right? Because now your knees bend and you have uh the not the handle, but the strap just above your knee. You're doing the same thing in a smaller range, or you even have your legs straight, but it's a lot smaller range. It's what works for you, right? So each exercise, Pilates or yoga, both have their place. It's how it resonates with your body, number one. And number two is how much strain and stress on your body you're putting. The difference, though, is um, so yoga is obviously body weight, right? And there is a lot of open range in certain poses. While Pilates, you are able to attach yourself to bands, springs, bars, and that will give you a little more proprioceptive feedback. So that is a little better in the sense that it's guiding you a little more through movement, but yet we can obviously extrapolate the whole movement and make it too big and end up injured. And that brings us also not only to Pilates and yoga, but we are, like you, Meredith just mentioned, Tai Chi, right? Tai Chi is open chain. Right? We spoke about closed chain and pseudo closed chain. Tai Chi is open chain, but it's a slow motion that works with that ground reaction force and works with self-resisted, because as you're moving in the space, it's almost like you're pushing a heavy cloud or a heavy wave of air against, you're pushing against it, and now you are actually doing your isometric there, and it's activating your joint, so it's a self-resisted. So there are different exercises. I don't recommend high intensity things obviously for us, but in among all the three that we have spoken today, I think all three have a place in rehabilitation and as a daily practice.
Thank you. Do you have a recommendation for strained shoulders? Sprained or strained shoulders?
Okay, so strained is it means you just injured it, right? You did something, you tweaked it. What is really strained there? Do you have a labral tear that became that woke up with a movement? Do you have a rotator cuff tear that became irritated because of the poor mechanism, because of the hypermobility? Did you cause a micro trauma to a tissue? You don't have any tears, but you cause a micro trauma to that tissue because the uh, pattern of movement was off. So what was really the strain? Is that a bursitis, a tendonitis? What is that going on, right? So initially, obviously, you want, and you know when they say just rest the joint and we'll get better? Eh, Rest has its place, but when I say rest, I don't mean put on a sling. Okay, unless it's really something that you went to the doctor, has been x-rayed, it has a place for a sling, and it needs to be that way. Other than that, I would say decrease the range of motion of that activity. Work on your isometrics. There are ways to work your isometrics for the shoulder. Ice and heat alternating is a great medicine. Okay. Avoid obviously straining into the same movement or the same direction. If reaching forward to pick up something is hurting now, shorten the lever. Remember, we go from straight. If you injure by reaching to your cup across the table, now you don't reach there anymore. Now you're going to have that short reach over here and maybe assist with the other arm, because now you're not doing it by itself for with the one arm, the shoulder that has been injured. So think of how you can continue to use it in a pain-free way. Injury causes fear of further injury? Are you anticipating that it's going to hurt and now you're protecting and overprotecting, which only leads to more weakness and instability? Or it's really going to hurt in certain directions, and now how do I prevent and avoid this from happening? And that's when you then, of course, need a healthcare provider if that lasts more than a couple of days, progressively better, right? So you have the injury day. It should progressively get better with some care, ice, heat, and protection of certain ranges in the movement. But if it's not getting better, don't wait a month before you see a healthcare provider. Try to get in within a week or so, 10 days, if it's progressively not progressing, getting worse or not getting better at all, because then you might need to address it before it becomes a chronic condition. And compression, right? Compression. So there are those kind of sleeves that you can use to assist the shoulder to stay more in connection with the body. There are specific shirts, like there's the Tommy Copper shoulder shirt, and there is Align Med. Align Med has also shoulder shirt type that keeps your posture and your shoulders in better alignment. Those are the two things that I like to look at myself when I feel that I am not performing as good. I do have a labral rotator cuff tear on my left shoulder, and on and off I will tweak it, but I just now know so well what triggers, what doesn't. And I wear it for my workouts. I do wear my compression, so it keeps me from getting into the injury point. I hope that helps.
Thank you. Kim asks, does it time of day make a significant difference, like exercising in the morning versus evening? And also, she's struggling with it being so cold.
Yes. So being cold because it's cold outside, or being cold even when it's hot outside, Kim?
I think being cold because it's cold outside.
Oh, we are cold now. I'm cold even when it's hot outside, so I don't know. Um, Respect your body again. Usually, if you're a person, so for me, I cannot go work out in the morning. Forget about it. I'm the worst. I'm not gonna have energy. My movements are not gonna be as fluid. It's almost like I take hours for my body work to wake up. Okay. So I do not work out before noon. It doesn't work for me, right? My best time to work out is after 3 p.m. and until 6. This is my window. And I learned it. That's my best window. I ate better at lunch. My food has digested well, and now I'm ready and I have nutrition and I feel good. If you're the person that you are more of a morning person, you wake up, you eat your breakfast, and you are a 6 a.m. person, and you just go and work out in the morning. Work out when you best have energy to perform the exercises correctly, where your brain is sharp, or as sharp as we can be with brain fog, right? Try to find that one moment of the day that your brain is sharper so you can focus on what you're doing. If you can't focus on the movement, if you can't really activate your muscles accordingly, if you're still half asleep, you have a higher chance to get injured. So, and being cold does not help, because if you're cold, you become a little stiffer, right? It doesn't feel the same. The risk of injury is higher. So warm up your body. If you like, let's say you have a portable sauna at home, get in there for like 5-10 minutes. If you have a red light, get under your red light for like 10, 15, 20 minutes. Warm up your body, or just get on your bike, recumbent, unrecumbent, elliptical, whatever it is, get some blood flowing, warm up your body, walk around the house multiple times, whatever it takes to get blood flowing, to warm up your body, then go into your session as well. So again, not on an empty stomach, because you could pass out or you could feel weak, not in a moment that you feel too fatigued, um, not on a day that you didn't sleep too well at night and you were just altogether a bad day. Maybe you just back off and do something lighter. Okay, not when you're chilling and freezing cold. Then you find a way to warm up as well. Hope that helps. If not, please follow up questions. I will take them as well.
Yeah,
Thank
thanks so
you.
much.
Elizabeth has a question. Um, there's suspicion from another professional that she may have EDS. She has a history of chronic medical conditions that overlap with EDS symptoms, even the things you discussed today. But she is. Do you have recommendations on how to seek diagnosis to begin treatment? As this condition seems rare, it does not seem common to find a doctor who specializes in it. How,
Okay. Where are you at?
Elizabeth, where are you located? I'm not sure if she's in Florida or not.
Can you hear me?
Yeah,
Yes.
now we can, Elizabeth. Hello.
Hi, I am actually very close to you. I am in Boca Raton.
Okay,
Um,
Elizabeth.
yeah.
So, okay, well, I'm glad you're close by. But at least it's warmer here than anywhere else. Um, so initially, genetics is so okay. Let's rephrase this. You need to rule out some rheumatoid diagnosis, right? So there's some like lupus, like um, uh, any other rheumatic disorders that can actually mimic or similarly present with TDS. Sometimes we have some coexisting things too. Um, so they're going to run blood. They're going to look if you have any other markers in your body that could cause those symptoms. Then if they rule out everything, then genetics is the next step. And you don't need to do them like separate. You cannot just run everything at once, right? A geneticist, Dr. Paldeep Atwal and Dr. Irman Fergani are the ones in the area that are the best diagnosticians for this. They're going to run your genetics and they're going to let you know if they found anything. Again, we just don't look only at panels for EDS. We are looking at other connective tissue disorders sometimes. And sometimes because of your presentation, they might choose some metabolic disorders. They might choose a full genome. They might choose a specific or full-blown panels based on their examination. So then that is put together with your rheumatologist results, right? And in parallel, you can get started easily with for example, a physical therapy program, right? Where we're gonna evaluate. So usually, for example, if you come here, I will take a full-blown history. It's much different than the regular PT would examine you. I have like a multi-systemic questionnaire, and when we sit together, we're gonna identify what's going on. Let's say that I look at you and we talk and I realize that your symptoms could be related to also mast cell activation syndrome. I will send you to a specialist that understands possible EDS diagnosis with mast cell. If I see you have symptoms that suggest POTS and we're still thinking, okay, this looking like AGDS or any type of EDS or a connective tissue disorder, I will send you to a cardiologist that understands the implications of POTS and EDS. And if I thought you had MCAS and POTS, this people I work with, they understand the implications and the relationship of this diagnosis. So it takes the village to take care of us. It takes connections as well. So finding the right providers is definitely key because otherwise you are correct. We're going to be running in circles and not get a diagnosis. We just keep getting loose labels for the symptoms we have, but nothing is connected and making sense to you. And there is no action to plan and get you better in the process.
Thank
Does
you.
that help?
Uh, Thank you.
Of course.
It does because kind of like the last thing you just said is kind of like I have like a lot of specialists I see, and my cardiologist brought up to me last year. She's like, you know, you go to a gastroenterologist for this, you go to an allergist for your asthma and this, and you have a spine doctor and have hip dysplasia and all these things. And she's like, I think we're missing something, but she wasn't sure how to get it done. I do see a rheumatologist. I have like some markers, but it doesn't explain everything. They're
Okay.
so slight. So it was actually quite helpful. My problem is just finding a place with insurance. Um, but that was really helpful because I just the geneticists that you brought up, I don't know how to spell their names. I was
Paul
kind
Deep. Patrice, can you put in there Paul Deep Atwal and Irman Fergani? Dr. Atwal is up in West Palm Beach,
of.
and Dr. Irman Fergani is in Mount Sinai Hospital. They are very good with connective tissues disorders. But again, just a little, it is hard to find within the healthcare, the health insurance for some specific reason. It's the thing is that we have so many moving parts when we come to certain types of care that we need, that the health insurance only allows us to pick one body part. Like in PT, you can pick one body part, maybe two, but you're not going to treat your whole body. Well, EDS does not affect your shoulder or your back. EDS affects you as a whole person. Right. So when we are working with you, we need to take into consideration all the diagnoses that you may have, and traditional physical therapy will not be able to put all those pieces together in the limited time, and sometimes even because they are actually having to work with maybe two or three patients at a time, depending on the setting you're going to. So I see your frustration. I think we all should be able to work, and insurance should cover, but the challenge is not the healthcare provider here. The challenge is the healthcare system and the insurance companies on how they are reimbursing, approving, or denying things. So that's the sad part.
Yeah, it's a tough thing.
Yes.
Yeah, so but I do see Patrice's message, not Patrice, but I see other messages which is really helpful. But thank you. I appreciate, sorry, I'm really shy. But
No, be a friend. It's okay.
I do appreciate your help because you're near me, I was interested in seeing you. I was just curious about because I don't know much about it myself. I was just my primary is like when I told her about the hypermobility and she saw me, she's like EDS, and I was like, I don't know. So, but thank
Yeah.
you. This was actually very helpful, so I really
Yes.
appreciate it.
No,
Thank you.
of course. And just so you know, I don't think Dr. Atwell takes insurance, but I know that Dr. Forgani takes insurance. It just really depends on the insurance you have more so than anything.
Of course.
Okay?
Thank you. Thank you so
Of
much.
course. My pleasure.
Mike Ryder had his hand up. Mike, would you like to ask a question?
Yes. So I came out of surgery not too year ago from a back surgery with all kinds of strange symptoms to find out through my sister's husband, who's a doctor, that our family has EDS.
Uh-huh.
And I've always been an extreme distance swimmer, and I can't do any exercise anymore without a lot of pain. I can't swim anymore. I try to do just bands or super light weights, and I suffer for days. And I walk a lot, but I'm just getting weaker and weaker and weaker, and I don't know what to do.
So when you say pain, are you talking about generalized pain or you're talking about back pain?
No muscle pain,
Muscle, just like
like
everything just hurts when you do something.
especially core between my hips and my sternum.
So
And
you get
just,
a,
it's like I've had 17 surgeries
oh,
all over my whole body.
that is a lot of them. Yes,
So
I can,
everywhere I've ever had a surgery
it
just
will hurt.
hurts so bad.
Okay.
I don't know
So
what to do.
so obviously I am not your clinician. I don't know your medical history in detail. It would be unfair to you if I actually gave you any specific advice. But what I can tell you is, um, you they would first thing it would have to be looked at is your spine creating any of those referred pain patterns, number one.
Most of
Number
my
two,
spine is fused.
okay. But it's still, you could be having, I mean, see, that's, I think, the misconception. I don't know if you remember that your surgeon told you he would go in and fix the problem. He never told you you're going to be out of pain.
Well, he kind of did, but
He
anyway,
kind of did. Okay. He kind of did, which is not true because
I know.
we expect to make you be pain free and we want you to be. But unfortunately, it's not something we can promise. We can promise we fix the problem if your body is going to respond or not. So there's a couple things we can look there. Number one, how much scar tissue you have accumulated from so many surgeries that could have been triggered every time you exercise. How could we modify those exercises? And I understand you're telling me even the smallest try of exercise will cause you to feel pain. So what is exactly triggering that? Another thing is 17 surgeries is a lot of trauma to the body.
I've never
It's
had
a
this happen before, though. Through all my surgeries, I've always beat it.
There is
And
the
this is
water,
the
the
first
drop
time
in the
I've
cup.
never beat it.
Yeah. The drop in the cup of water that makes the bucket makes to overflow, right? It could be it. Again, I'm giving you ideas, but I don't know your
Okay,
case
I hear you.
specifically. But there is the possibility of the brain becoming hypersensitive to that stimuli, to so much that has been going through. So the brain now perceives a challenge of minimal exercise as pain, which should be just a sore muscle from doing something, becomes pain and lights up the brain like a Christmas tree. Have you considered any neuroscientific approach to desensitize the brain and see if that could help you at all?
I'm trying, but I'm trying to get into UC Davis genetic research, but
Okay.
it's like jumping through flaming hoops to
Yes,
get
it
there.
is. And you cannot afford jumping right now.
And it's
Um,
just, I mean, I'm
so
puzzled to say the least.
yeah. So
And I
I'll give
have
you
the
a
weirdest
couple.
symptoms. I mean, I can't, I've developed terrible tremors. My hands are turning, they look like skeletons. I'm going into huge atrophy. Uh,
Mhm.
I don't know what to do. It's a little frightening. I never had these symptoms. I guess my sister's husband, the doctor says there's only been 150 known cases of the type of EDS that we have. How true that is, I don't know, but they went everywhere to John Hopkins, to the Mayo Clinic, to Cleveland Clinic, to NIH, and they found out what it was at Vanderbilt.
Okay. I
So
see. So yeah, you
I'm
have, you
puzzled.
see, yeah, it is puzzling. I obviously don't know your case in detail, so it would be unfair to you if I gave you any
I get it.
specific record. And we are in a group too. I don't want to get into details of your personal medical history in here, obviously. Um, but I would consider number one, have you discussed with your doctor any forms of pain management? Like, I'm just throwing things out there like
I've been
spaghetti
on
right
pain
now, right?
management for 22 years through my all my surgeries.
Yeah. No,
It
that I
sucks.
imagine that. Um, but honestly, have you looked into programs like the Gupta brain retraining or the FD, I forgot the name of the other one. I can look into it and Patrice can reach out to you. There are a couple
That would
different
be
brain
great.
trainings to see if that could maybe reset your brain. I mean, I know it's not going to change your genetic markers because we are what we are, but maybe that pain, reprogramming the pain pathway in your brain could be something that could be helpful. I don't know much about you, but I'm just trying to give you something that could maybe lighten up your load and enlighten you to get to try something new that maybe will help you.
And
I can reach out and give you some information on that.
that would be great. I was an exercise therapist in a group that specialized in neurological diseases.
Look at you.
And
Isn't that
I tried
challenging for us?
everything, but that
Yeah.
was before anyone knew anything about EDS. And
Yeah.
so I talked to head therapist, and she just kept saying, "I am so sorry." and said, just try to do what you can that we used to do with the patients. And it was all done in a
Yeah.
pool.
Well,
So hydro,
obviously, yeah, obviously, in order for me, your case is even a little more, and each, I wouldn't give even to a patient that was a straightforward hypermobile Ehlers-Danlos syndrome patient a recommendation like this without knowing. So, I would have to, in your case being so complex, I would have to really understand your entire medical history so I could be more assertive. But
it's
one
really
of the things I
hard to
would,
find anyone to do that, to talk to, I'm shooting blanks basically.
yeah. Well, the one thing I would say, and again, I could be just blobbing here, look into brain retraining programs and
Okay.
see if I know we are not going to change your muscle atrophy and things. It could be atrophying because you're unable to move and exercise, right?
I
It could be
still do it.
atrophying because,
Oh, I
yeah.
still exercise, but it kills me.
Exactly. So if we're trying to modulate pain, looking to just make a note on that, because if you also throw out a Google on a Google search, brain retraining programs for pain, you're gonna get a list of the top ones, and Gupta is one of them. FD, I'll send you that one. I can't remember the name by
That
heart
would
right
be great.
now. Yeah, there is a couple things, and I think I have an ebook that I got. Patrice has your email. I'll shoot that one for you. You can read that. That's something that I have that I got a resource for free. I'll give it to you,
I
and
would
hopefully
greatly
we can give you
appreciate it.
some guidance at least. Okay?
I would love that. Thank you so much.
My pleasure. Mhm.
Dr. Perretto, we have a couple more questions. Do you have time to answer them?
Yeah. Let's do a couple more. Go for it. We'll stop at a 4:15.
Okay, sounds good. The next question is, when should someone with HEDS look into CCI, craniocervical instability?
So you should be looking at CCI if you're having vision disturbances, if you're having numbness, tingling, weird sensations on your tongue, if you're having facial numbness, neck numbness, so you touch, you're like, oh, this is weird. You're having high pitched ringing in your ear. You have voice changes sometimes. They don't have to be all there, by the way. Okay, each patient is different, so don't think you have to check every box that I'm saying. I'm giving you a couple of the symptoms that you see when you have that we examine on CCI. You have obviously that pain to the base of the skull. You feel a lot of feel like bubble head, right? Feel like your head is like too heavy to stand on top of your body. You have obviously pain with range of motion. You get dizzy if you look in certain directions. It depends on your instability direction. Um, what else? You might be developing some disturbances walking, right? Some increased loss of balance, numbness to your shins, or difficulty coordinating movements. These are a couple of the symptoms. Like I said, hoarseness, difficulty swallowing is another one that could be present. Um, and these are a couple of them that I can recall from the top of my mind. But yeah, if you and obviously the pain is not only to the base of the skull, it could be coming up into the head because of you start compensating. A big one that I notice patients with upper cervical instability, they do this, they kind of do this and walk around. They say, "Oh my God, my neck feels so much better because I'm." It's almost like you're holding the neck up. So I have heard some patients saying that, and these patients were diagnosed with upper cervical instability. How scientific that is, please don't hold that against me.
Thank you. Next,
Uh-huh.
my shoulders tend to sublux in my sleep, especially when I'm on my side. Is there anything I can do or wear to help this?
Uh, so there are a couple. Okay, the first thing I would say, if you have shoulder issues and you're sleeping on your side and you have to because you can't sleep on your back, that's me. I can't be on my back. I need to be on my side. Hug a pillow, like get a body pillow, right? And that will keep your shoulder a little more in line versus dropping in and sliding out. That's a one. If your pillow, the one you're sleeping on, is too thin, not only you're gonna end up rolling your neck down further, but you're gonna end up rolling your shoulder forward because now you have to accommodate your head, right? So make sure that that pillow fits the space in between your shoulder and your ear, and ask someone to look at you when you're lying down. If you actually look like you're kind of in line, right? And then you hug that pillow. That's another one. Your mattress shouldn't be super soft. Sometimes we think soft is better because it's comfortable, but soft is not good because we end up getting things completely out of alignment. And because we stay on a position for hours because we're sleeping, and then we are awakened eventually by pain because something's lead out or got strained, right? That is already problematic. So you do want to make sure that your mattress is on the firmer uh, side of it, but not firm enough that it's hard. That you lie down and you say, well, but then my joint's hard. It's a firm, softy kind of sensation that you're gonna have. So you have some support as well. And then if that by itself doesn't work, uh, I don't like to recommend this, but then I would say you can wear a compression short or long sleeve shirt, like I just mentioned, Tommy Copper, Line Med. Those are compressive. They're not as tight, but yet enough to keep you aligned. I do not like to recommend compression at night because if they roll up, they can cut your circulation. So it is a matter of you trying and seeing if it is actually staying in the right place for you and if it's actually helping you with the joint as well. And then kinesio taping before bed, but for us with skin sensitivity, sometimes that's also not a good idea, but you can try and alternate all the methods as well.
All right, last question. Oh, wait, Carolina has her hand up. Go ahead, Carolina.
Can you hear me?
Yes.
Yes. Hello, Carolina.
Hey, how are you?
I'm well. How are you?
Nice to meet you. I
Nice
have
to
a
meet you.
question about you talk about like the integrative and how like different doctors have to see you in order for you to get better. And
Mm-hmm.
but my experience is that I've been diagnosed for 2 years now for Lois Dietz, but there is no like I would say like in any hospitals, like not even Mount Sinai have like a multidisciplinary team or
Mm-hmm.
L'Oreal or any that
Mm-hmm.
I know.
True.
So I heard about Mayo, but I don't like I think it's like in Missouri. I'm not sure. But I guess what I'm understanding is that you need to have like a cardiologist and then a PT trainer that knows about LDS and like maybe somebody that can help you with your, like what you eat and because
Mm-hmm.
like you cannot train, like if you're not like receiving the correct diet, right?
Mm-hmm.
If your system is not working because with a lot of I don't know like if everybody's LDS here. I know we all have different issues,
Yeah.
but my problem is that I'm losing mobility and I heard that it's because, like I'm not eating right, but how can I eat right if my system is not absorbing the
Mm-hmm.
nutrients? But there's not
Mm-hmm.
a team that works together. So I'm stuck in the system for two
Yeah.
years. So I
Yeah.
don't know, what would you recommend?
So Lou-Dietz syndrome is what we are talking about. It's another type of connective tissue disorder that affects actually now a different fiber, right? It's tenexin. It's not collagen, but it's part of, all right? So it's still gonna be the same characteristics, a bit different. Um, you're correct. There are a lot of institutions that are very, very, very good institutions. They're doing a great job out there. But they have a team, but not everyone in the team is really versed on the EDS or on the LDS or any other connective tissue disorders. They're cardiologists, they're gastrointestinal specialists, they are, rheumatologists. They are part of a team, but they are not really with an EDS specialty clinic, right? What I learned in my professional and my personal journey is that I had to reach out to specialists everywhere. So I have a specialist that I work with for patients and I work as well for myself. They're out of state, right? So I have, with my knowledge, I end up being able to manage a lot for myself. But when I send you guys, um, like I will send to someone else that has a clinic in West Palm for one thing, and then I will send the cardiology that's down in Pembroke Pines for another. And then if you tell me you have an upper cervical, you're telling me you have symptoms that are suggestive of upper cervical instability, and I examine you and I think that's what it is, I will have two or three different surgeons with my primary group being up in Maryland. And that's kind of how I operate. I try to give you the best in the country uh, there, because sometimes locally we don't have. And it is true and it is sad. But I end up even buying a health care insurance for me privately that, and obviously that we have to afford that to be able to afford that. But I Leah realized that it ended up turning up cheaper to pay a healthcare plan that was private and that allowed me to go anywhere in the country instead being limited to a system and to a network that I couldn't get the care I needed.
I have a
So
about
our
that.
village is spread all over the country. It's not a village that's tight around the corner, unfortunately.
Yeah, I have a question about that, but because what I heard from my provider, from my insurance provider, is like because I already have the diagnosis, like they would not accept me in any particular insurance.
It's possible too. It is possible, unfortunately, that that
Now I'm
happens. It
stuck
depends
in the
on your
system.
level of health. I have the diagnosis and I was accepted because I'm healthy overall, right? So I don't keep going to the, because I do a lot of the management as well. So I'm overall considered healthy with the diagnosis. That's a one. Also, your healthcare insurance, for those that don't know, you can request a one-time exception deal of approval for the care of that specific physician or that specific therapist. And it's going to be a back and forth. It's going to be a little bit of an argument and all. But if they cannot, it's by law, if they cannot provide a professional that can fulfill your need inside the network, they will have to pay for someone outside the network.
Okay. Yes, but they, of course, they're gonna say that, that they have the people that.
They will, and then there will be we challenge. We do this here with patients. We send letters, then sometimes there's a peer-to-peer that we have to do, and and they will ask you to also, you're gonna have to go to that provider, and then when you're gonna go, you're gonna provide that evidence that that provider couldn't address your needs, and then they eventually gonna approve you. It's a little bit of a hurdle race, but you get it.
Sure,
Overall,
maybe
you
I
can.
can
Yeah,
ask my
it's
insurance
just
to.
they will beat you by getting you tired of trying to appeal. But if you're persistent, you get it.
Great. Thank you very much. Maybe I will try
Of
my
course.
insurance to
Thank you
help
all
me.
so much for attending. We really appreciate it. And if there were questions that didn't get addressed, Marissa, I am going to ask Dr. Perretto and I will email you. Just a reminder, tomorrow at 3 o'clock, Dr. Perretto is going to be with Dr. Brent Anderson, who is the founder of Polestar Pilates, talking about Pilates for EDS patients. And she will be actually doing a course with Dr. Anderson about working physical therapists and Pilates instructors working with EDS patients in the future. We'll keep you posted about that.
Yeah.
Thank
Yeah.
you again.
And thank you everyone for joining me today, for taking the time to be here, to exchange ideas, to exchange this conversation, to help me be a better clinician. And if today you think was helpful, you can always join us once a month. We'll be here as well. And then just follow me on social media, visit the website. We're always bringing up more information to you as much as I can put together and as fast as I can put together. Alrighty, everyone, you take care. Bye bye.
Thank you. Bye bye.